Okay, good afternoon, ladies and gentlemen. I think we'll make a start because we're already running a little bit over, a little bit late for the afternoon session. So it's my pleasure to chair a session devoted to ambulatory care, a better option for patients, and I'm very fortunate to be joined on the stage by my colleague, Dr. Chinnarai Kamarli, the Chief TB Specialist for USAID in Kyrgyzstan. To introduce myself, I'm Dr. Jay Archer. I'm a TB Specialist working for MSF. So we have 4 presentations with a video for the first session this afternoon devoted to ambulatory care. And obviously it's a model of care that's it's taking us closer to a patient-centered model. So a type of healthcare that is more adaptive to patient needs. In many of the countries I support, actually patients are demanding this and really not wanting to be hospitalized for many months to start TB treatment. We're starting to develop evidence that a patient-centered ambulatory model is a cost-effective one. But there are clearly challenges that we'll hear about in the region of transitioning from hospitalization to start TB treatment over to a purely ambulatory model.
Good afternoon once again. My name is Chinnarai Kamarli. I'm in charge of TB portfolio projects in the Kyrgyz Republic from USAID. I would like to present our panelists. This is Mr. Martin van der Boon, advisor to European WHO office, Aelita Ibrayeva, chief specialist from the Ministry of Health in charge of TB, Ernesto Jamarillo, doctor from the World Health Organization, and I think we can start our session from a video from Belarus. This will be focusing on the difficulties of DOT in clinics.
У меня никаких подозрений не было, просто мне нужно было делать плановую флюорографию, и вот, в общем, сделала. Честно, я была в шоке, испугалась, как, потому что туберкулез для меня это вообще что-то очень-очень древнее было. Я не думала, что люди вообще сейчас болеют там. Но меня успокоили тем, что, возможно, это пневмония, так что не волнуйтесь, и лечили меня первое время от пневмонии. Я лежала в больнице уже, получается, почти 3 недели, там как бы решали еще диагноз. И потом мне вот сказали, перевели уже на другой этаж, уже конкретно лечить туберкулез. Но мне как бы повезло, что я в Минске живу, и в Минске лежала в больнице, поэтому я периодически потом уже могла ездить. Там, домой, днем там. Тяжело было, потому что и ночевать нужно было в больнице. Пытались там как-то договориться, чтобы ночевать дома, уже не было палочки. Но это не разрешали. Каждый день ходила для приема препаратов на амбулаторном лечении. Была на больничном, когда ходила каждый день. Поэтому с графиком, в принципе, нормально, но было неудобно то, что в основном просили приезжать с утра. И когда я с утра выпиваю таблетки, мне потом целый день плохо, и я лежу как овощ, получается. Я просила как-то, чтобы там дали на ночь, но этого нельзя было сделать, и вот это было накладно, и далеко есть, да. Я час добиралась туда. Да, я давно знала о возможности видеолечения, вот Дмитрий мне рассказывал о ней, и я постоянно спрашивала у врачей, когда я могу перевестись. Вот когда мне закрыли больничный, меня практически сразу же перевели на видеолечение. Сама выбирать время на видеолечение, и поэтому мне удобнее пить вечером на ночь таблетки. Значит, вот я в удобное время сажусь, включаю телефон, включаю видеорегистрацию, открываю контейнер, показываю, что там таблетки, высыпаю их на салфеточку и с прозрачным стаканом воды все запиваю благополучно и включаю видео. У меня получается, что медсестра не онлайн смотрит мое видео, так как я вечером пью, это где-то уже часов 11, 10-11 перед сном, и поэтому медсестра уже смотрит на утро. Я, наверное, 2 раза случайно просто проспала это время, мне до 12 нужно было выпить таблетки, потому что закрутилась, завертелась и забыла. Позвонили, сказали, что там будут решать, что делать, ну, в принципе, все нормально. Да, мне сказали, что 2 дня пропуска, там, без звонков, без предупреждений, то это все. Проблемы, с которыми вот я столкнулась, это, во-первых, длительность лечения, то, что очень долго нужно лежать в больнице. И, ну, я считаю, что можно им пораньше срок сократить, потому что не заразная уже в это время палочка не выделяется. Особенно тем, которые не минские, все время лежать и не ездить домой практически там никогда. Им там разрешают где-то раза 3-4 за все это время вылежать, то, смотря какой врач. И еще проблемы с тем, что мне, например, сейчас у меня нет больничного, но я не могу выйти на работу. Вот мне врачи сказали, что я еще считаюсь заразной, и поэтому справку мне никто не даст, что я должна сидеть дома. Вот, конкретно в моем случае получается, что жить как бы нам не на что, потому что муж учится, мне, соответственно, работать нельзя, и на что жить непонятно. Нет, я сейчас не работаю, меня уволили. Вот. Это связано с болезнью. Получается, я очень долго была на больничном. Где-то у меня всего получилось около 11 месяцев больничного. И потом, когда закрыли уже меня уволили сразу же с работы. Разные люди бывают. Я не скажу, что все были так в шоке и против того, чтобы я возвращалась на работу. Мое непосредственное начальство, оно, в принципе, было за то, чтобы я вернулась. Но я понимала, что на ставку я не смогу работать по состоянию вообще. Мне тяжело, я устаю очень быстро. Вот. И я просила на 0,5 ставки, но высшее начальство сказало, что...
Well, we have just seen the video from Belarus. Now we will move to the next presentation of the session. This is a Martin van der Boom presentation, Technical Advisor to the European WHO Bureau. His presentation is called Person-Oriented Model of TB Assistance Concept for the...
Thank you very much, Nara and Jay, and just a brief word of thanks, appreciation, gratitude to the organizing bodies, MSF, and also the government of Kyrgyzstan and the NTP, the Ministry of Health, so much appreciated. I'm happy to, or I will try to stick also to the given time, which is not an easy task, and the after lunch slot is not the easiest one, but let me try to keep you interested for the next 10 to 15 minutes. I'm not sure if I need to... this works this way. Thank you very much. Sorry. So, just a brief slide, and we had we had strong pleas and appeals this morning, also from Senya, from TB People, and we just watched a video. I think we probably cannot have too much about or from this, because let us bear in mind it is all about the people, the bacteria, and here you see a few key messages enshrined. So people, bacteria. You also see more specifically that it is about the people we care for. You see in the centerpiece at the bottom a patient who is obviously, to put it in lay terms, not well at all. But you see also, and this is what we're striving for, and that was also depicted and illustrated in the video just then convincingly, we want people-centered care to have happy patients, but not just for them to be happy from the ethical and humanitarian or humanity perspective, but also to help them follow their treatment and to complete it and to obviously have better treatment outcomes. So the boy in the picture has a smile on his face. You also see the little boy, the baby, sitting in the arm of his mother. So also parents are there, they are involved, and also healthcare workers are involved. So we need to keep all of them involved and meaningfully and involved in a dedicated fashion. So this is the, sorry for a bit of a busy slide, but that was done on intention, a lot of color here. But also just to boil it down to a few key messages. Obviously, in the world of TB, we have never been in such a promising place or space or spot. Coming from, or when we think about the appointment of Dr. Tedros, our Director General of WHO, who almost immediately after coming to term was happy to step in and say, look, I'm also in for TB. So you see him holding here the NTB sign. And here we had recently, it was already alluded to by our colleagues from the Russian Federation, a ministerial high-level conference in the Russian Federation in November last year with very high-level attendance globally. And also this is leading then to the General Assembly, the high-level United Nations General Assembly in New York this year. But it is not about the plans, it is rather, or not about the commitment on paper, but it is rather of what we make of the commitment and how we put this, all of us, into action in our respective and complementing roles. In the middle you see from the WHO European Regional Office our Health 2020 policy, which is in line with the SDGs that you see at the top. The ones obviously being very interlinked when you think of TB, and we know it is a social and multifaceted, multidimensional disease. It's also about education, it is also about sanitation. It is not just the mere biomedical health aspect. And you see the regional plan that was informed by the NTB strategy. We want universal access, and we also would like to, and if we have our mathematical modeling realize or come true, then we would have a lot of patients saved and a lot of patients cured, which we hope and strive and work for in our roles. Just a brief picture, and some of the slides or parts of the slides you may have seen before. This is preaching to the converted here still, but when we speak, especially not just to ministries of health, but also to ministries of finance, which is ever more important because we sometimes get stuck with recommendation. It is a lot about funding, about cost effectiveness. It is interesting to see, and I direct you to the upper left-hand part of the slide, that TB, or reducing TB if done correctly, is one of the single most disease-specific interventions with a very high yield of cost savings, as you can see. And this was published by the Economist, and was done by a Copenhagen think tank. You can see that $1 invested well would yield actually savings of more than $40. On the right, there is something, as all countries are going through epidemiological transition, and as we as WHO in our region serve 53 member states, and they all have different epidemiological patterns and profiles, we see, though, that generally countries and the epidemiological transition goes where we have an aging population and also then a higher probability and count of comorbidities. And obviously we know that as we have more comorbidities, TB is more likely to come from dormant to infectious stage. So it is ever more important, speaking of people-centeredness, that healthcare workers are able of managing or treating, caring for different diseases, different conditions, and obviously TB is one of them. And on the left-hand side, you see what we know already. If we really want to eliminate TB, then obviously we have to be very focused and leave nobody behind, especially the prison population, the elderly. I was already explaining this just briefly before, injecting drug users, and also those suffering from alcohol addiction. Very important to address them as they're more vulnerable, and also TB and HIV co-infected. At the right-hand side, you may not be able to see this, but the message is, or what you see in red is what is or was available. These were figures from last year for research. We already had research as one of the key topics in the previous session, a need for research when it comes to diagnostics, but there's also a need for research when it comes to other areas. And there's the gap is the lila here, and you see there are gaps across the board. So we are still certainly not satisfied with the involvement of and the contribution of when it comes to funding for research. A slide that we have most recently adapted that we used before, and a few key messages here. Why the period 2011-2015? This was the period that was covered by the previous regional WHO TB action plan that was endorsed by the 53 member states of the WHO European region. And the message that you see depicted in somewhat a lighter color green is that there was some improvement across the board from the left hand to the right. And you see that this regards TB notification rate, the success rates, MDR-TB detection rate. I will not read out all for the sake of timing. However, and we shall not be complacent, and I would be the last to try and come across as such, we are certainly far away from the targets and the vision that we all are trying to collaboratively get to and achieve. We have 54.7% of treatment success rate now in the drug-resistant TB cohort, which is better than a few years ago, but still far away from the target that is enshrined in our plan, the regional plan here, of 75%. Now, we have developed this current plan, and we are reporting back on the plan actually to the member states, the 53 member states of this region in September, which is part of our mandate. And we obviously did an analysis of the previous plan, including the lessons learned, and developed, together with the member states, civil society, technical partners and donors, the current plan. And one here, as you can see, one of the 6 areas of people-centered care is explicitly spelled out. Needless to say, though, that people-centered care and people-centeredness is inextricably interlinked and spans across all the 6 key strategic directions. I will make the case for this. Now, let me take you on a brief journey on a project that we have been implementing over the last 2 years with the support of Global Fund. And this is a project that was devised for 11 member states, of which the results, and I will present a few preliminary results at the end of my presentations, may also be replicated and adapted to other parts of the WHO region. So with the support of the partners mentioned here, in PASS, the Center for Health Policies and Studies in Moldova, Chisinau, is the principal recipient. WHO, one of the technical partners, together with the Stop TB Partnership and others, have been working on these goals here with the objective of, and you can see it, to increase the political commitment. You could see before we are in a very good era of high-level political commitment, but it is not just, of course, the decision makers meeting in Moscow or New York, but it is also about the commitment on the ground. And then also technical assistance, and I will come to what it actually entails now more in detail. So what is it about? So there is high-level political commitment. So indeed we had the appointment of high-level national focal points in those 11 countries. That was, so to say, facilitated by a high-level letter that was signed by our regional director, Susanna Jakob, the then executive director of the Global Fund, Mark Dybel, and the executive director of the Stop TB Partnership, Dr. Lucica Diciu, last year. And so this has yielded high-level focal points in the countries that often go beyond the level of the NTP and the Ministry of Health, and I will tell you why this may be helpful and important in a minute. You also see here that you have, we have advocacy missions. They are actually civil society organizations that have been assigned on the ground in the countries that help and bring forward and implement the technical elements that I'm going to explain in a moment with regards to how is actually more people-centered care done. So civil society supporting this strongly. At the bottom you see, under the second one, also the technical assistance. We have been conducting a lot of technical assistance missions with the partners involved, and also the interregional exchange platforms and missions. So what we are doing here obviously the exchange with people from different countries is very fruitful and useful when it comes to sharing good practice examples. Now again, a bit of color, but also containing a lot of content. These are elements in here on the left. Actually, that is one of the key milestones or products within this project, a people-centered model of TB care, collectively developed by the partners involved in this project, which actually attempted to give advice and collate and develop advice on what is people-centered care, by whom could it be provided, so the healthcare provider side, human resources, but also which kind of care is provided at which levels, and also, and importantly, the alignment with sustainable financing mechanisms. So there has also been the involvement of health economists. And one good also example of how this work has benefited not just those 11 countries, but others is that thanks to the data surveys that we conducted, also the global TB data collection and reporting was updated, and you cannot see what is written there on the right, but what it is actually how the percentages of hospitalization for drug-resistant and drug-susceptible TB and also the length of stay vary from country to country. And again, keeping with me your curiosity, I give some preliminary data on this, how it has evolved, but it varies, and you see it is very heterogenetic across the countries of our region. But generally, it is actually improving a lot. And of course, and I will come to that, it's not just reducing hospital beds, it is not just reducing the percentage by which people are hospitalized, but at the same time, we have to obviously capacitate outpatient services and ambulatory care, including primary health care, to take on those patients so that they can be adequately and in a dignified way and people-centered way be treated. So again, this is what it entails. This, we called it, or we coined it, the blueprint. It is under it is under adaptation in all those 11 countries, health financing, and it also contains a bed forecasting tool, and it also contains hospitalization criteria section, which countries find helpful. And by the way, I would like to announce that the Regional Office for Europe is currently also developing a guidance document on TB infectiousness, which we are hoping will be published in a few months' time. Now, why people-centered care? So coming a little bit now to the health systems or to the system side, I let you read for yourself. What is important, it is also fully in line with our regional healthcare or the healthcare framework and that of our WHO colleagues on the health system side. So you see here, and it is on the organization, on the health needs and expectations. And you saw this very strikingly and convincingly in the videos that we saw, right? The lady from Belarus lost her job. She mentioned not all, but a lot, commuting, the costs, the lack of choice often with regards to patients. I listened the other day, I take one extra second to say this, to an impressive gentleman who has actually suffered from MDR-TB and is HIV positive. And when he said he's a native, anyhow, he put this across very vividly. He said, with regards to my HIV treatment, they were asking me for choice, how would you like it? With regards to my TB treatment, it was rather paternalistic. Choice was a term that wasn't really an option there to be discussed. So we are working on this, and all of us are here together today to exchange on how and why. So we defined it after long discussions with our scientific working group and partners as an efficient and integrated set of affordable, accessible, acceptable health services provided in a supportive environment. And it is for the prevention as much as it is for the diagnosis and treatment. So it is all together. Here just a brief slide on where we are and what it is our analysis has given us when we look at the health system's building blocks. The governance. We have been, we realize that there is a difference or difficulty with coordination between the sectors in just about any country, and that is not the the mistake of the people involved, but it takes governance and leadership to make this or streamline this. There are inefficiencies in the health system often, or we have seen an overinvestment in tertiary and secondary healthcare, whereas there has been a relative negligence on the primary healthcare sector, and also involving civil society, which has been found to be very useful. Actually, I mentioned it before, we have examples of civil society being involved in those countries and actually supporting the patients and doing and contributing in a complementary fashion the work of the NTP and governmental services on keeping the patients on treatment. With regards to also what the lady described and was said before by Xenia this morning, the stigmatization and all that comes with it. Health financing. Often, and that is also what I've heard and I'm hearing all the time, when, for instance, it is managed that there is a hospital bed reduction, and countries here all present have been striding tremendously impressively forward on that. We have very good figures, again, when it is linked to the support and the capacitation of primary healthcare and ambulatory services is impressive. But we need also the health financing that goes with it. So often this is line item budgeted, and when it is line item budgeted, sometimes the budget then is simply lost. So obviously when I'm a hospital manager or when I'm someone in charge and I'm losing the funding for the amazing, let's say, difficulties that myself and my staff may have encountered in making this possible, then obviously this is the worst incentive, or rather in disincentive, that I could have. So we're also helping countries to help with that. That's the governance also. The financing mechanism, of course, has to be in place. That we do what was also alluded to before from the colleague of Tajikistan, actually, with regards to children, that we do meaningful and effective active case finding, that we, and also keep the patients on treatment. Okay, I will speed up a little bit. So I will quickly go through this. We have had quite a lot of examples on why we need this, also some evidence. So it is about designing the care, who should deliver the services, but also improving performance. And also, as you can see, to manage the services. This is one element, one possible patient pathway that obviously is adapted in the countries. And you see that hospitalization should, or there are also hospitalization criteria here, but hospitalization should only be applied or in special circumstances. What we do and what we help countries do is a mapping of services, facilities, and types of care involved, and also which kind of healthcare worker could then be involved. This is one of those mappings that we have done for a country that I will not single out or name, but just to give you an idea, and it may sound abysmally trivial, but often or rarely we have seen that this is done to the extent that it is complete and fully accurate. But this obviously is one of the first steps to know how people-centered are we, and where do we need to go, and what do we do to do, or what do you need to do with the financing. I have 2 more slides. So I'm not a health financing specialist, but I'm fortunately surrounded by many, and I'm learning a lot from them. So these are also some elements that we are helping the countries on the health financing side to introduce. I'm not saying, or I'm clearly and explicitly not saying that any of these should be a preferred option or that they are superior to others, but often it has shown that some of them can actually help to be more people-centered when it comes, for instance, we have a lot of bed-based financing. A bed built is a bed filled, usually, you all know this. And of course, we are trying to move away from this, so more performance-based and per capita payment. The last slide, or the second last slide, I didn't want to hold away from the preliminary data that we have been collecting of those 11 countries. So, very promisingly so, we have actually the countries that have adapted or introduced more policies and practice on people-centered care, also in their legislation. And then importantly so, there has been also, and I direct you now to the last two columns on the right-hand slide. Hospitalization rates have actually decreased considerably, and also the length of stay in those countries has decreased. Of course, we cannot say, and I will be saying this myself because I will preempt one of your questions, of course, to which extent there is a causal link. We are still working on how we can possibly quantify and evaluate that. But we do see that generally when the countries do adapt people-centered policies, also involving health financing, that this goes into a good direction. So a few conclusions, again, possibly a bit trivial, but rather to spark and kick off the discussion afterwards. There is progress across the board. Also, I didn't show you so much epidemiology because there's time limitations, but I'm happy to discuss with you further. We are still far from reaching our targets, although our region has the fastest decline in TB incidence and mortality in all world regions, but it's very heterogenetic. So we need to do a lot more of out-of-the-box thinking, and we are very much encouraging from WHO side the evidence gathering and production of you, and then also when it comes to providing this for us to look at, this is very much helpful also with developing new guidance and guidelines. I would like to acknowledge my colleagues here who have contributed also to this, and also partners, the PASS Center, the Stop TB Partnership, Global Fund, USAID, and our country office and headquarters colleagues. Thank you very much.
Спасибо, Мартин, большое. Я, наверное...
Thank you very much, Martin. I suppose I would also suggest for all our questions to be kept until the very end of the session. Now, I would like to ask the next presenters to be as specific and succinct as possible, because we are 20 minutes behind schedule. And I think that this would be a very logical continuation after Martin's presentation. This is the optimization of the TB service in the Kyrgyz Republic. And I would like to give the floor to the head specialist of the Ministry of Health of the Kyrgyz Republic. Good afternoon. Currently, tuberculosis, I do apologize for this. Currently, TB in the Kyrgyz Republic, well, the indicators are still high, the levels are still high, and the social and economic decline that we've experienced back in 1990s has led to a situation where the healthcare budget shrank. We started having problems with the procurement of TB drugs. The quality of treatment was not in line with the contemporary requirements, and there was a total lack of social support of the patients in the course of their treatment. This has led to a situation where our epidemiological status and epidemiological situation was really desperate. The morbidity indicators were more than 100 per 100,000, and mortality were above 16 per 100,000 population. Quite naturally, the Kyrgyz Republic adopted a number of necessary measures to tackle this issue. It started working with the legislative and regulatory framework for TB control. We started implementing the DOTS strategy of the World Health Organization, which is aimed at detecting and treating tuberculosis. And the country receives effective TB drugs, laboratory and diagnostic services. And such TB diagnostic and treatment services are now provided free of charge in accordance with the law on the protection of the population from tuberculosis. As far as the legislative framework is concerned, in line with this law, certain bylaws have been approved. And from the very beginning, as soon as our law was passed in 1998, a number of programs were approved. TB 1, 2, 3, 4, 5 up until today. These programs are still in existence. They get approved. We have activities and plans of actions developed for these programs. But it is necessary to say that besides these programs, tuberculosis is one of the main components in our healthcare reform program, which is called Denso Look. This program has been in existence for a few years now. It includes 4 components besides tuberculosis. That's the cardiovascular diseases, mother and child health, and HIV infection. Despite all the efforts that have been invested in the development of the legislative and regulatory framework and in drug procurement and provision and the establishment of all sorts of different programs, we still needed to undertake some new measures and new steps to completely revamp our approaches to TB control. So, after 2 years of extensive analysis of the work of the TB system, an analysis, by the way, was also taking place of the human resources, financing, etc. So after all that, in January of last year, the government approved the so-called roadmap. And we call it a roadmap in our circle among the health workers, but the official name is the Actual Plan for Optimization of TB Services in the Kyrgyz Republic for 10 years. The purpose of this plan of action is to reduce morbidity with resistant forms of tuberculosis, and the most important thing is to increase the efficiency in the utilization of existing resources aimed at providing TB services to the population of the Kyrgyz Republic. This plan contains 3 main components: restructurization and optimization of the network of hospitals, strengthening primary health care, and expansion of outpatient care, as well as improvement of laboratory service. What do we expect? What are the expected outcomes of this plan of actions? Annual detection of at least 70% of TB cases at the primary care level, TB treatment success rate at least 85% in primary healthcare institutions, reducing the number of TB beds in the hospitals by more than 2 times over a period of 10 years, and the reduction of unjustified hospitalizations in TB facilities by 10% annually. All in all, the economic effectiveness of the restructurization by 2020 will reach more than 139 million soms. The roadmap consists of 3 periods. Short term, this is the period that we have already started with our action plans, with our programs, then the midterm period and the long-term period. As I already mentioned previously, there are 3 components, and let me briefly go over what is in each one of these components. That's increasing integration of TB services at the level of primary health care and expansion of outpatient treatment. So that implies capacity building for primary health care in the area of TB. Incentives for PHC healthcare workers for detected and successfully treated cases. It is noteworthy that while working with the Mandatory Health Insurance Fund, we have developed a mechanism for such incentivization, and currently payments are affected of the savings that have been generated thanks to the restructuring and the reduction of the number of beds that took place last year. And I have to say that primary health care, the doctors at the primary level, have faced tuberculosis, have looked tuberculosis in the eyes, if I can put it that way. There used to be a side, but now, no. They welcome patients with their arms open. And this is one of the joint accomplishments of ours together with the Mandatory Health Insurance Fund. I would also like to emphasize that the government has approved this regulation. It was not an easy task, by the way, but still that regulation included one mandatory item that we really had to fight for. That is the fact that all the savings from restructuring and the optimization of the service would be channeled to the purchases of drugs, to the strengthening of primary health care, improvement and expansion of outpatient services. That means that not a single penny would go back to the budget. Since the Republican budget does not allocate any additional financing for us, at least we could not expect that, because in our difficult times, it's very difficult to get anything, to get a penny out of the Republican budget. It took us a really long time to reach this point, but we have managed to finally approve this successfully, and all the savings, well, maybe not all the savings, but at least a portion of the savings is given to primary care. As far as the hospitals are concerned, well, most of the hospital beds have been reduced, have been cut. In the next let's say that the largest portion has already been cut, and optimization is still underway. The beds are being redesignated, so the work is underway, and in the short term, this will be the most active period for optimization activities. The laboratory services, they also need to be optimized because we have a lot of laboratories that perform microscopy, and we are also involved in this reduction of the lab capacity that are not loaded with work, that are idle. What are our expectations? As I mentioned previously, we have 2,229 beds. This is what we used to have, and our expectation is that by 2019, their number will go down to 1,600. And all the departments in the districts, rayon and inter-rayon level, the smaller hospitals, all of them will simply disappear. Let's put it that way. We will maintain the Republican and the oblast or provincial hospitals, and the rest will simply become their branches. We have a network of labs. We have 131 laboratories that perform sputum microscopy, and we hope to only have 40 by 2026. We also have problems in the implementation of this plan of actions. Let me tell you the way it is. As a matter of fact, not everyone is happy with our plan of actions. In particular, the hospitals themselves are not very active. The MPs, the government is getting involved, and it takes a real long time to tell everyone that this is actually for the better of the population. Then the administration is unwilling to cooperate, and it's clear why they're afraid of losing the funding. They're afraid of losing their spot. But this is a painless process because we do not lay off any people. We may cut the overblown staff that we used to have in the hospitals that are simply redundant, that do not work at the moment, that are not loaded with work. So what are we going to do next? Next, we're planning to continue optimizing and restructuring the service. We are planning to improve the quality of diagnostics and treatment. We have high levels of resistant TBs in our organizations. We have a system of transportation, maybe not in all provinces, but it's working. It's working in most of them. We're planning to introduce a new system for payment of services. It's already under implementation, and I hope that next year we will be able to demonstrate some results. Then the development of the new system of payments at the level of hospitals and at the level of primary care. At the level of hospitals, we are now developing a mechanism. We're working on it. Then the development of plan for transition from drug donation programs to state funding, improvement of the system of TB patient registration and recording, and active engagement of the communities in the successful treatment of TB cases with an emphasis on the vulnerable groups of the population. Thank you. Thank you, Aelita. With your permission, I would like to say a few words in addition to what Aelita just mentioned. We already have certain results whereby results-based payments and performance-based payments have already taken place. certain payments have already been made to the nurses and to the doctors that were following up on the patients, whereas the average monthly salary of a nurse is 5,000 to 6,000, and then per patient, per treated case, they get 12,000 sums for a susceptible form and 24,000 for a resistant tuberculosis, and 75% of that is given to the person who actually follows up on the patient. So you can imagine this is huge financial assistance. So they're actually running after patients now, and the money has been reinvested, as Aelita mentioned, and I think that this is a great outcome, and thank you very much for that. Now, the next presentation, I would like to give the floor to Ernesto Jaramillo, patient-oriented.
Good afternoon, everybody, and thank you to MSF and to the Ministry of Health of Kyrgyzstan for inviting WHO and inviting me to this presentation. I'm aware that we are short of time, so my main message comes in the first 40 slides. So after that, you can cut me short. Okay, I would like you to be concentrated on the on this slide and the next one. That's all what I need from you. Look at the numbers that are in circle. These are the results presented in Mexico last year, the preliminary results of the clinical trial on shorter regimen for MDR-TB. So you see the difference in treatment outcomes, in favorable treatment outcomes, which is a kind of proxy of a cure rate treatment success, right? So around 80%. Control arm, 80%, 80.6. Intervention with a shorter regimen, 78.1%. No statistical significant difference, right? Clear? Now the slide with the results of the Delamanid trial, phase 3 clinical trial. So you see the results for treatment success in the Delamanid trial, in the Delamanid arm. So 78 plus 4 means 82% of treatment success. And the treatment success in the control arm, 76 plus 5%, 81%. Clear? Next slide, and I can finish my presentation. Because next slide is about what is the key question that comes to my mind when I see all these two data sets, right? What is the common element in the four arms? In the four arms of these two randomized controlled clinical trials conducted by very competent people, without no restriction in the budget. Here we have Sevin, USAID funded the STREAM trial. Otsuka, major pharma company, funded the Delamanid trial. What is the common denominator in the four arms? Well, without spending not too much time, is that roughly 80% of treatment success is feasible when a properly designed MDR-TB regimen is delivered with a patient-centered approach. So the question was, is it the length of treatment, shorter, longer? Is it with new drugs, without new drugs? Is it scratching the head? Is it limping? No. With all the limitations of clinical trials, what these two trials are telling us is that when you deliver patient-centered care, you can get fascinating results. And actually, I can tell you that the people who were behind these trials have shared with us their surprise, actually their frustration, because they underestimated heavily what the control arms could deliver. Because the global TB report data of WHO says 52%. This is what countries are reporting as treatment success globally. 52%. So it's going to be very easy to demonstrate efficacy. It's going to be very easy to show that shorter regimen or the Delamanid is good. But because a proper trial has to be conducted, well done, patient-centered care was one of those elements, DOT, then surprise. So I can finish here if you want. Can I continue? So when you look to the guidelines and documents from WHO, I would like to highlight two types of documents. We have on the left hand all those related with treatment guidelines, how to use moxifloxacin, how to use kanamycin, how to combine it, how many drugs, for how long, for how many, and blah, 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 blah. Very important. Without drugs, we cannot treat the people with MDR-TV, right? And on the other hand is the Cinderella of the whole equation. All the guidelines related with patient-centered care and support. But most of times, those are heavily neglected, ignored, forgotten, sidelined. But they are the essence of the whole business, right? I'm not going to enter into the details, but cannot resist the temptation to mention the guidance on ethics and human rights. Patient-centered support, which I'm going to go in more detail if time allows, right? Nutritional support, infection control. So in short, TB treatment, right, and patient-centered care are to work hand in hand. It's like clapping. You cannot clap with one hand. All what you can do is noise, but you cannot clap. So you cannot cure and end the epidemic of MDR-TV just by this obsession just on the drugs. Because I'm getting sometimes the impression that some members of our TV community and civil society are addicted to drugs. All the time talking about the drugs and the drugs and the drugs. And I'm so happy when I was invited to this meeting when I saw it's about patient-centered care. Wow, I want to be there. Right? So quite often in the past, when we are highlighting the importance of patient-centered care, oh yeah, we do patient-centered care. All our patients receive incentives. What do you mean incentives? Oh, they receive a box of chocolate, or they receive a voucher for transport, and they are happy, This is patient-centered care. So patient-centered care is not the cherry on the top of the cake. Patient-centered care is the heart of the cake. Is deeply embedded into the cake. And that begins with planning the response to MDR-TV. So when people are planning management of MDR-TV, most of times, and I have experienced firsthand, begins the how many drugs, how many patients, high dose moxi, low dose moxi. Yes, patient-centered care comes later. No. It has to be planned well in advance at the same time. So the companion handbook has a chapter fully devoted to patient-centered care elements, which is, if I may have to define, is ensuring that the needs, the values of the patient are at the center of the response, rather than pretending that the patients have to adapt to weak healthcare systems that don't care too much about the local needs, the values, and the needs of the patient. So the guidelines of WHO of last year, for the very first time, conducted a systematic review of the evidence on DOT. Some colleagues inside WHO were even telling me, oh, don't go that far. Let's keep recommending DOT. Everybody knows that DOT is very important. But the evidence on the value of DOT had been never reviewed by WHO with a systematic review, grading of the evidence following the procedures adopted in 2008. And the response, the outcome of the whole thing, was quite surprising for some people, including myself. The outcome was that DOT does make a difference in terms of treatment outcomes. Quality of data was not the best. There were not randomized controlled trials looking at that with proper control of all the elements, right? Because this is a complex intervention. However, the result did show that what the ethics guidance said in 2010 is valid. DOT in the absence of a patient-centered approach is unethical. Unethical to do DOT if you do not have a patient-centered approach, right? You are abusing, you are violating fundamental rights of patients when you do not ensure a patient-centered approach for DOT. Why DOT? Human behavior is complex. It's unpredictable in a reliable manner, specifically for complex behaviors like long-term adherence to treatment. So the outcome of the systematic review made last year came with conclusions that are kind of obvious, but were never being produced out of a review of the evidence. Health education and patient counseling. HIV community have been doing that for ages. And TB community has said that for quite a few years, but it was never the product of a recommendation after assessing the evidence. Patient counseling, health education, strong recommendation to do it systematically. When Ksenia was saying this morning about how she was scared and hating the doctors, she doesn't want to engage with doctors. That means that the fundamental element of trust between healthcare providers and the people who are in need of care and treatment for MDR-TB is not there. So how can we really get treatment success in those conditions? Health education, patient counseling, first step to ensure trust and to understand what comes ahead for patients. I'm not going to enter into all the details because this is well described in the guidelines of last year, just to insist that patient support includes health education, patient counseling, psychological support. It's a stigmatized condition. It's a heavy, heavy impact in the lives of patients and families. Some of them come to the diagnosis already depressed. Depression is emerging as a risk factor for tuberculosis. And if they are not yet depressed, they can get depressed when they are told what they have to do to get cured, right? Material support. And material support is, again, the result of assessing the needs of the patient. Do you need transport? Do you need food? Do you need some kind of services that can enable you to have adherence to treatment? So, model of care, I'm not going to enter into the details. The previous speaker have discussed this in detail, but the evidence was validated again. Is not DOT with patient-centered approach in the place where the doctors think is best. Is where the patient prefers to receive treatment, where the patient believes is going to be more feasible. So the centralization of model of care stays. Major innovation in those guidelines of last year, digital health tools. We saw the video of the patient that was presented at the beginning, video observed therapy. 5 years ago, impossible to think about that because smartphones were not. Nowadays, I have seen in some countries, the beggar has a smartphone. The beggar, give me a coin, give me your exchange, and then suddenly the phone was ringing, and then he drew a smartphone. It was so funny. So, and we have to tap on those resources, right? I brought something like 80 copies of the handbook on how to use digital health tools. Hope that you got one. If not, the document is available in the website. But digital health is one of those tools that we in the TB community have to tap. We have to modernize ourselves and ensure that people do not waste their own resources and health systems don't waste resources by forcing a DOT that could have been done through video observed therapy. And this is the cover of the handbook that I have presented before. So, final slide, 2 slides. I would like to see this as the face of TB care and management. The patient is like a flower. In this case, the patient is having a mask as well. But if we treat the patients as a flower, with care, with support, with love, with empathy, with compassion, with tolerance, with sympathy, with all these ingredients that ensure that the cake is so tasty that you want it to try again. Another slice, right? And this is probably one of the examples of the recipe we have to check before going to the kitchen and cook that cake. Are you really ensuring that the patient has been evaluated to guarantee that all those elements have been properly covered? I'm delighted when I see in your program a session on palliative care. Palliative care is the patient-centered care for those who have very limited treatment options. And we are using the mortality data for advocacy, but we have no clue the condition under which people with MDR-TB are dying. And having a dignified death is also a fundamental part of a patient-centered approach. Hence, palliative care has to be also included in that list in such a way that people really are at the center of the response, right? Driving the response and not just at the receiving end. So, thank you very much.
Вообще не послать пришел. Thank you very much, Dr. Jaramillo. I have a role of bad cop today, and Dr. Chan have a role of good cop. But you're perfect. You had perfect timing. So thank you for that. So I would like to give a floor, whether there will be a presentation or not, but I would like to give a floor to a person who has passed through that disease, and she has become public assistant, a supporter. She helps other patients who are facing and coming through the treatment course. Please let me invite my Dilek Kızı.
The previous presentation was amazing and interesting. Thank you. Hello, everyone. Hello. Nice to meet you. So let's start. Меня зовут Бегимай.
Well, my name is Bigimai. I'm 24. At this moment of my life, I'm quite a happy person. This is because I had TB, tuberculosis. For the first time, I got sick when I was 15. This disease has probably come to me from my mother. She was sick at that time, but she failed to manage. And in 2008, when she started that treatment, she had a lot. I remember she had a lot of, doubts in efficiency, effectiveness of the treatment because she had multiple side effects. After 6 or 7 months of her treatment, she dropped, taking pills. She just and she passed away. The 31st of October 2008. At that time, I was in a children and a TB hospital, hospitalized with an open form, blood spitting, complicated. I improved. I survived. But after 6 months of my happiness, as I thought that I was happy, 6 months after I got a relapse again. After flu with complications. But second time, getting better took me a lot of time because I had a drug-resistant form and similar side effects as my mother, and that was hell difficult. I understood that if I don't take pills, I will follow my mother. But colossal, great support from my father, who from the day one of my treatment until the last day of anti-TB drug taken was just close to me. Thanks to him. He just wouldn't leave me alone. Well, in fact, standing here, smiling, telling you my story is very difficult to me. And please trust me, struggling for your life is something that other people who have been in a similar situation with TB can understand me really. Every person needs support from relatives, from people nearby, from the loved ones, from parents. In fact, this is one of the reasons why level of the disease is so high in our country. Just imagine, the patient with TB is already weak. He is in depression, and he expects at least 18 or more months of treatment to go. The patient needs support and help in any type of support. I was lucky enough, more lucky than other people, because I had father nearby. I'm repeating again, he was a great support to me. I was lucky. Well, it's been 7 years that I'm healthy. I've got my master degree. I'm studying my English, and the best event in my life, I have a 2-year-old daughter growing with me, and she fills my life with a big sense. Actually, she's in the kindergarten now, and she makes my life more complete and happy. I know, support her, or in a Challenge TB project implemented by KSTB, give me a chance to help other people with TB. In fact, the work that I do is something that I really feel good about. I'm not afraid of patients. I talk to people, I contact them. Of course, I take all necessary precautions, because I understand that I have been in a similar situation as they are, and I'm happy to see their smiles in the course of my work. I think this will become all my life business. Well, the most bright first of patients I remember were children. They had a short-term regimen. I think it was 9-month hospitalization or so. The girl Sumaina and boy Elias, a 2- and 4-year-old, they got disease from their mother, who was sick with TB too. And when I first time saw them, the first thing I really wanted to get them treated as soon as possible. I'm a mother too, and they are children. Every day, visiting them, giving them pills, being compassionate with them, helping them, supporting them with all my heart, and and feel happy after they completed their treatment. I think this is something I will never forget. They are now in the kindergarten. They are absolutely okay in their life. We keep in touch with them. I contact with that family quite often. I'm aware about their success of these boys, of these children, because in the end you become kind of a relative, very close to your patients, because you have helped them for a long time. You have been supporting them and passing through difficult moments of their life, and they become really close to you. In reality, I'm trying to find its own approach to every patient I work with. I know that I have part of responsibility for them to get cured, because it depends on the person who brings them medication. It depends how the treatment will go. I can make it more funnier, if you like, less depressive. That's why I'm trying to be positive all the time with them. Smile, support them, say them good words, motivate them, and I think I'm successful in that. And when you support your patients, it's not just a job, a work that you do, or you have to do something. This is really because this is something coming from the bottom of my heart. And deep of my soul, I'm really willing that my patients become healthier. Sometimes I replace friends, people nearby, neighbors, I don't know, because most of people have turned away from them. They become alone, the outcasts, lone people with no friends. And I'm trying to refill this gap and be close to them. In the course of my work, I share my own experience, what helped me to get treated. Because this is not only medication on time, this is proper vitamins, proper food. And my little help, even though input is very inconsiderable, but I believe it makes their life better and treatment easier. Recently, I learned about TB people group. I have become a member with that team. We are on the same site now. I also now work with the association on TB treatment, whose goal is to stop and end TB. In the end of my speech, I would like to help you that I really want to help decrease the burden of TB in our country, so that people wouldn't suffer, wouldn't lose their relatives, and put my own input, even though small contribution, but change something. Show people with TB that it's possible to get treated. You can win TB. You have to trust and take medication. And I want patients get better conditions during treatment. It's not only about the during treatment, but after the treatment as well. I want people not to be discriminated, not become castaways, so patients wouldn't be afraid with the disease. I believe this will become true. Thank you. Bigimai, thank you so much. Today, when Ksenia was asking, raise your hands, who had TB, only 4 people raised, and you were number 5. I was in fact shocked with the fact that results of the study that have taken place in the south of our country about stigma and discrimination. Stigma and discrimination turned out to be a key moment why people avoid treatment in outpatient. It's not because capacity is low, not because of lack of medication or something. Self-stigmatization is so high that people hide. Some comments, people say, I would rather have a cancer. It's not, I can't, infect other people, and other people will treat me better, even though I will die. And that was something that was shocking us. Their family members that don't want to, their relatives to be at home when treated because they're afraid of get infected. This also adds to the stigmatization. The thing you mentioned, the stigma, discrimination, we need to have a whole block of activities done. Most of the discussions we have are usually, we discuss opinion of doctors, of medical, of clinicists. And point of view of a patient is a factor that can really help move to the outpatient treatment. Okay, now we have a session of question and answers, and then we will make a summary. Any questions, please? Yes, please. Begimkul Halikulov, Medicine Sans Frontier, TB project in Minsk city. My question is about payment for services, payment for nurses to reach effective treatment of TB with the patients. If this is success of a treatment is measured by its outcome. After treatment is over, for MDR TB is 2 years. What is approach to that? Because if payment done per case after the treatment, which is 2 years after, by this time this person may be fired already. I mean, what is the system of payment per patient? What is your approach to the system for compensating for service? That is one question, and the other one as well. You mentioned that you don't fire staff, but if you close facilities staff stays without jobs. How do you deal with that? Thank you. Well, to answer question number 1, I will ask to Ms. Ibrahimova, Aygul Ibrahimova, to answer. But I think question 2, Elita can make the answer, because we have made assessment of staff. Most of people in those facilities were close to pension, and they had more staff, the supportive staff. Supporters, teachers, cleaners. This was not about nurses and doctors. So, in fact, we have a shortage of TB doctors. Alita, can you also answer on that? Okay, staff. In fact, this is a painful question. Most of inpatient facilities, they have a huge administrative and support staff, like non-medical staff. we actually conducted analysis for each inpatient facility, and there have been some staff that shouldn't be there, like pathologists, gynecologists, and dentists. They didn't have any conditions to be there, not speaking about being enrolled into the stuff. What exactly they were doing was a big question. Then after we, on every facility, we made an analysis and asked direct question, what is exactly this person doing? Nothing, just getting salary. So mechanically, pathologists and other staff were simply, fired, and there was no questions. The questions were with the medium-level medical staff. We call medium-level specialists, where it was shortened, but not that much as not like 50% firing nurses, but we offered jobs at the level of primary healthcare facilities. But because we, in some cases, we're not allowed, in fact, to fire a lot of people because this can become political. And the first thing that we do have a shortage of some of professionals. On the other hand, we have too many medium-level health practitioners and like nurses, and we have reviewed their functional in terms of references, and some functions have been delegated to those doctors that moved down to the level of nurses. So we're addressing this problem, and it's still not resolved yet. So the part, the part of staff was fired, especially like supportive staff. Health practitioners, like doctors, were left. There are many.
But at the same time, most of them are nearing their retirement age. Some of them have already retired. Some of them are saying, well, I am retired, but I will still keep on working. So some of them do try to hold on to their places, and they're still there. That's the way it worked out so far. As far as payment is concerned, Nursultan, can we please have a mic over here? You see, it's very interesting. Take nurses. In one hospital, for instance, you have 20 nurses. Then after layoffs, they're without job, but at the primary care level, where you have a rural medical point, for instance, taking the population into account, they have a certain staff, right? So you cannot add any more nurses to that unit. Yes, you're quite right. Not everyone agrees. I think that only a small portion disagree to go and work at the primary care level. First of all, in the hospital, they get additional add-ons for working in the TB hospital. Secondly, in the hospital, they can make a little bit more money. I'm talking about medium-level healthcare professionals. And as far as transfer to the primary care level is concerned, right, certain functions have been delegated, and now they have some add-ons to what they're getting paid. As for the staff that we have at the primary level, yes, the staff is there, but what can you do? What can I do? We are trying to move them forward, if I can put it that way. And then, putting our nurses there, this is one of the attempts that we're making. Well, in reality, from the very beginning, the Ministry of Health has had the following policy. They've been very careful about healthcare professionals, especially doctors, physicians, and nurses. As far as teachers are concerned, for instance, just imagine that you have a hospital, you have a small number of children, and you have a huge staff of teachers that also work elsewhere. So this is just an additional source of income for the teachers, and you don't need to keep all these teachers, whereas their salaries are significant. So these are the things that had to be addressed and were addressed. As far as the doctors are concerned, well, not a single doctor lost his or her job, I can tell you that. And this is an intention of the Ministry of Health for all the doctors to remain within their profession. They can be redistributed somewhere else, with the exception of the doctors that, well, for instance, we have these cases when you have a TB doctor who's 75 years old. It's time for retirement. I mean, 75, what can you produce? What sort of a product when you're 75? Give a minute. As far as nurses are concerned, same thing. They're all rotated, they go to general hospitals, they go to primary care, they are not left without a job. As far as payment is concerned, from the very beginning, the Mandatory Health Insurance Fund was of the position that they would pay for results, for performance. Two items can be considered to be result. First of all, treatment completed, so the person has been treated. So these are the two possible outcomes. Either the patient is cured or the treatment has been completed. The other parts of the possible treatment outcomes are not paid for by the Mandatory Health Insurance Fund. I forgot to say, please introduce yourself so that we know who's asking questions. A point of clarification. Alexei Nikiforov, MSF Moscow. So treatment completed and patient cured. We can only know that after 1 year passes, right? In 1 year's time. In 1 or 2 years, right? As soon as the treatment is completed, a notification is issued to the Mandatory Health Insurance Fund, and this is when payment takes place. It's result-based. They can undergo treatment for a year or a year and a half. Okay, the person has completed treatment, but statistically they have completed treatment. The cohort is closed only in 1 year's time. That means that if they complete treatment in 2015, when will the healthcare professional get the money? In 2016 or in 2017? No, they get the money right there on the spot. This is the decision of the TB doctor and in the family medicine centers. I think you all know, right? You have TB01. This is the form. As soon as you close this form, you issue notification to the Mandatory Health Insurance Fund. So you don't actually wait. So they don't have to wait for a year, right? Okay. A question, well, actually, questions about the presentations, please, now, only. Wonderful. Then I would like to give the floor to Dr. Achar, who will sum up. Oh, sorry.
Just one small comment on what Dr. Ernesto presented. You said it's the cake and it should be the heart of the cake, but we should remember that the cake has a price. It's not cheap. It's maybe more expensive than the bread. And it should not be considered as a top-up of something, relying on, it should not be considered as an additional humanitarian assistance to patients, but it should be the core activity of the national programs and not only dependent on the external additional funds. It should be considered as part of the core budget of their activities.
Thank you. I agree. But I think whenever we have to spend money, we all spend money every day, right? We want to spend it in things where we see yield, return, value for money. The data is showing very clearly. You invest in patient-centered care, you save lives and protect public health. So, what other reason you need to make the decision, or to get the government to make the decision? That's why in my message, my call to fight, demand, work for ensuring that treatment is delivered under patient-centered care. A push for drugs alone is not going to do the job, right? I would like to believe that the title of this meeting was the result precisely of the trials that were presented last year, right? That there was certain realization that, well, actually, yes, the patient-centered care is as important as the medicines. After the release of the results in Geneva, we received a lot of demands and questions from people who wanted clarity about the meaning of the trials for the sake of the drugs. Right? Some people saying, please produce a clarification. Some others don't produce anything because this can confuse people more. Nobody was saying, oh, WHO has to make a very bold statement about patient-centered care, which is what worries me a lot. And is my main message to you all. Let's ensure that access to drugs is embedded in the context of patient-centered care. The evidence shows that otherwise it will not produce the impact that we expect. Thank you.
Спасибо. Right, I think it's time for us to close the Q&A session. Now I'd like to ask Dr. Achar, who will sum up the entire discussion. Я просто хотел бы буквально пару минут уделить тому, чтобы подытожить те 4 замечательных презентации и видеоролик, которые мы в начале данной сессии просмотрели. Итак, 2 обширных темы я здесь записал на основании видеоролика. Первое – это страх. Да, она получила диагноз, она испугалась. И с моей точки зрения, если бы мне, например, МЛУ-ТБ поставили диагноз, я бы тоже сначала испугался бы. Вторая концепция, она потеряла работу, несмотря на то, что она принимала участие на всех этапах системы, она много месяцев была госпитализирована, ей было сложно, были врачи, которые предписывались, сложно было соблюдать предписания. Несмотря на все на это, несмотря на то, что она все это делала, она считалась опасностью для своих коллег и работу потеряла. И в конце концов, ей вообще сложно было со своим партнером выживать. Следующая презентация Мартина. Мартин затронул важность того, чтобы слушать пациентов, чего же они хотят. И в видеоролике в самом начале это также было подчеркнуто. Он упомянул широкие вариации в области уровня госпитализации по всему региону работы проекта TP REP. И он также поговорил о рентабельности, данные о рентабельности амбулаторного ухода по всему миру. Еще один вопрос, который у меня для Мартина сохраняется. У меня не было возможности этот вопрос ему задать, сделаю это во время перерыва на кофе. Так вот, как же стимулировать, как поддерживать страны с тем, чтобы они работали также и с министерствами не только здравоохранения, чтобы обеспечить финансирование, потому что, да, Минздрав концентрирует бюджет страны только лишь в очень небольшом количестве стран. После этого мы перешли к замечательному примеру Кыргызстана, где используется законодательная правовая база для того, чтобы подключить Министерство финансов, использование законодательно-правовых баз, несмотря на сокращение бюджета здравоохранения, для того, чтобы откорректировать то, как выделяются средства здравоохранения на туберкулез. Я услышал, что существует множество вызовов в других странах, я это тоже слышал, но они рассматривались и решались посредством изучения способов решения трудностей. И, кстати, стимулы в здравоохранении предлагаются на страновом уровне. Вот это я, пожалуй, услышал впервые, и похоже, что мы видим весьма стимулирующие результаты. И после этого мы перешли к презентации Эрнесто. Он и до своей презентации сказал мне, что презентация будет провокационной. И могу сказать, что ничего там особо провокационного-то и не было. Мы говорили о медсестрах, которые на самом деле беспокоятся о пациентах. Он предоставил нам данные, которые были опубликованы на основании 3-й фазы исследования. И, быть может, мы как бы в последние несколько лет не в том направлении двигаемся. Был вопрос подобного характера. Он также упомянул важность модели лечения, ориентированной на потребности пациента. Это, наверное, ключевой багаж, который мы должны забрать с собой на основании этих исследований 3-й фазы. О торте мы много поговорили, и о том, что в центре торта, и о вишенке на торте. Но главное, что мы говорили о важности образования в области здравоохранения. Мы говорили о важности текущей поддержки наших пациентов. Несмотря на все это, нам необходимо двигаться по направлению к модели, ориентированной на потребности пациентов. И, наконец, мы прослушали Беги Май. Она рассказала о своем опыте болезни туберкулеза. Ее сила меня вдохновляет, она поговорила с нами о нашем опыте, но она также сразу же упомянула важность той поддержки, которую она получила со стороны своего отца. Это хороший пример фотографии, которую она показала. Упоминали ее жизнь после того, как она была диагностирована. И ведь жизнь наших пациентов – это не только статистика в графиках и в таблицах, не только те цифры, которые мы показываем, не стоит об этом забывать. И, наконец, пожалуйста, присоединитесь ко мне, давайте поблагодарим 4 выступающих, эту команду, которая для Минска создала видеоролик. А теперь, пожалуйста, пьем кофе.